Hello and welcome to the first video on adrenal gland pathology. In this first part of the series, I'm going to focus on just doing a quick review of steroidogenesis in the adrenals, talk a bit about congenital adrenal hyperplasias, and then we'll look at a summary of adrenal cortical disorders, and then in the subsequent videos we'll look at adrenal insufficiency, excess, and then talk a bit about what we might call functional adrenal disorders, which aren't as talked about in the more conventional sense of endocrinology. So remember with adrenal steroidogenesis that there are three primary layers in the adrenal gland: the glomerulosa on the outside, the fasciculata on the inside, and then the reticularis, the most innermost layer right up against the adrenal medulla. And in each of these, there are a series of stratogenic enzymes. The first one being cholesterol desmolase, which essentially converts cholesterol to pregnenolone. And this is found within the mitochondria. And then pregnenolone in the various layers is converted directly into progesterone or 17-hydroxypregnenolone. And then this can further be synthesized into aldosterone in the glomerulosa, so there are enzymes for that. And some of the most notable are 21-hydroxylase and 11-hydroxylase. Notice that the majority of these are CYP450 enzymes. Many of them are found in the endoplasmic reticulum in the cells in these different layers. In the zona fasciculata, pregnenolone can be interconverted into 17-hydroxypregnenolone via 17-hydroxylase, and then it can be converted into 17-hydroxyprogesterone, and then via 21-hydroxylase into 11-deoxycortisol, and then finally into cortisol. And there's a similar pathway to make the other primary glucocorticoid, which is corticosterone. And then finally in the reticularis, the primary pathway is to make DHEA, which then becomes sulfated in the plasma to DHEAS. And then DHEA can act as a pool in the body for interconversion to androstenedione, and then via aromatase into estrogen and so forth, into estrone, for example. So that's a review. I had mentioned in the anatomy and physiology videos that there's really no such thing as a so-called pregnenolone steal. Pregnenolone steal is a hypothesis that when we have lots of stress and we're making lots of cortisol, we'll use up the pregnenolone instead of using it for example, DHEA synthesis. But as you notice in each of these three layers, pregnenolone is made independently via cholesterol. Okay, so that's going to be important as we look at the congenital adrenal hyperplasias here next, which are genetic disorders, usually of a deficiency of one of these enzymes in these different pathways. So congenital adrenal hyperplasias are relatively rare. They're autosomal recessive diseases, and again, they result from mutations of one or more of the steroidogenic enzymes. The most common enzyme deficiencies will involve the 21-hydroxylase. Next in line would be 11-beta-hydroxylase, 17-alpha-hydroxylase, 3-beta hydroxysteroidehydrogenase, and then lipoid congenital adrenal hyperplasia usually involves deficiencies of many of these different enzymes. And so that one actually ends up producing very little, if any, of the adrenal steroids. And typically, the more severe the congenital adrenal hyperplasia, the less compatible with life that's going to be. So these are very, very rare because most of those infants don't survive that mutation. Most of these are going to result in either excess or deficient production of the different sex steroids, and that can alter the development of primary or secondary sex characteristics. And the clinical presentation is going to vary. So let's look at the most common one. Up to 95% of cases of CAH involve mutations of 21-hydroxylase, and they can be either partial mutations, that's what we call the non-classic form, or the classic mutation is when you have complete lack of 21-hydroxylase activity. So if you go back to the steroidogenic pathway, 21-hydroxylase is very important for all of the different pathways, but in particular with the aldosterone pathway, we end up getting no aldosterone. We'll also get low cortisol, but because we can shunt through the DHEA, we generally get high androgens in that case. And so blood pressure will be low. with the deficiency of aldosterone, there is an infant's salt wasting. So remember, aldosterone works to retain sodium in the kidneys. So with very, very low aldosterone or no aldosterone, we urinate out all the salt, and that results in severe hypotension. But there'll be signs of early puberty with the elevated androgens, in males early virilization, or in females virilization with something like PCOS. Labs will see increased renin activity, so the macula densa in the kidneys is sensing the low sodium levels, and that is causing the release of renin into the blood to try to raise the renin-angiotensin-aldosterone system. So renin will be increased even though blood pressure is low, and there'll be increased 17-hydroxyprogesterone, which is a metabolite that needs to go through 21-hydroxylase. That's going to be increased here. And then potassium will be increased as well. So that's by far the most common form of CAH. So low blood pressure, low aldosterone, and high androgens. In terms of 11-beta hydroxylase, that's about 5% of CAH cases. And here again, we'll have low aldosterone, but we'll have elevated 11-deoxycorticosterone, which is along that aldosterone pathway. And this results in fluid retention with hypertension and actually decreased renin. So opposite the 21-hydroxylase, renin here is going to be low. Cortisol will also be low, and again, androgens will be high. But in this case, the blood pressure is going to be elevated with low renin and low potassium. So sort of the opposite of the 21-hydroxylase. Very rare would be the 17-alpha hydroxylase, and this would yield ambiguous genitalia, undescended testes, so this might result in more intersex characteristics, and that could be genetically if the baby is female, XX, this could lead to lack of secondary sexual development. So in this case, we'll have high aldosterone with hypertension, so the aldosterone pathway will function fine, low cortisol, low androgens, and therefore also estrogens, and then again elevated blood pressure, decreased androstenedione, and decreased potassium. And then getting again into the even more rare would be 3-beta hydroxysteroid dehydrogenase, where we get low levels of all the different adrenal steroids and virtually no steroidogenesis, significant and severe salt excretion in the urine, and the patients will often have female-like genitalia because of lack of the androgenic support. And then lipoid CAH is actually lack of the star protein. Remember, that's the protein that conveys the cholesterol from the outer to the inner mitochondrial membrane to be synthesized into pregnenolone. This is very rare because it's usually not compatible with life because there's no steroidogenesis that results from that. So for the purposes of the clinic, we typically are thinking about these if we're working with infants or children, and we're seeing, for example, the characteristic signs of the 21-hydroxylase deficiency with very low blood pressure, low cortisol, but again, the high androgens. So that would be something just to keep in mind for that. That said, these are usually going to be picked up fairly early in life, and a lot of them will not be primarily presenting to your clinics where you'll make the diagnosis, but it's good to understand what the different potential patterns can be. Okay, so let me do an overview here of the different types of adrenal cortical disorders. Remember, of course, we have the HPA axis with the paraventricular nucleus in the hypothalamus secreting CRH. That then travels via portal system to the anterior pituitary, causing corticotropes to release ACTH from POMC. And then the adrenal gland releases cortisol, DHEA, and aldosterone. Remember, the main signal is going to be renin. The ACTH increases synthesis of aldosterone, but not the release. So we can have either deficiency of the adrenal output or excess. So let's talk about deficiency here first, adrenal cortical insufficiency. So that would be decreased cortisol, possibly decreased androgen and DHEA. We don't usually focus on the DHEA as much as cortisol and aldosterone for the clinical purposes, because we typically, with low DHEA, will not see dramatic, at least obvious clinical signs. But definitely with low cortisol and aldosterone, this can be potentially life-threatening. So with adrenal cortical insufficiency, there's weakness, fatigue, weight loss, very common, orthostatic hypotension, hypoglycemia, muscle aches, GI disturbances, even low-grade fever is sometimes possible as well. And then sugar and salt cravings is going to be your classic adrenal cortical insufficiency. And that can be either primary, secondary, or tertiary, or peripheral. So if it's primary, that means that the gland itself is not putting out these hormones. And the most common reason for that is Addison disease. So Addison or Addison's disease is the most common cause of this is autoimmune disease. It's actually destruction of the adrenals. And usually this is going to be found in conjunction with other autoimmune diseases like Hashimoto's thyroiditis, pernicious anemia, vitiligo, things like that. So that's Addison disease. If it's chronic, if it occurs more acutely, if there is, for example, an acute destruction of the adrenal, and this can be from several different things, most commonly from infection of Neisseria meningitidis, the bacteria that causes bacterial meningitis, disseminated intravascular coagulation or endotoxic shock. So basically from septicemia, we can have an adrenal collapse. And this causes rapid collapse of cortisol and aldosterone, causing severely low blood pressure, low glucose, low sodium, so severe hyponatremia, and then increased potassium, metabolic acidosis, and then that could actually be fatal. So that's why an adrenal crisis is something we have to take very seriously. And that's why the critics of naturopaths who use the word adrenal fatigue are arguing that this is nothing like what the functional adrenal fatigue is. This is an actual life-threatening event. Now in Addison disease, because the gland is not putting out cortisol, the pituitary continues to churn out ACTH to try to stimulate the gland. But remember that when we make ACTH via POMC, the POMC also fragments into melanocyte-stimulating hormone, MSH. And that's going to cause skin and mucosal hyperpigmentation. So the classic presentation of primary Addison's is going to be with the hyperpigmentation. Now secondary adrenal cortical insufficiency would be loss of pituitary ACTH. And the most common reason for that would be a pituitary adenoma, like a macroadenoma, or something like Sheehan syndrome, or empty sella, etc. We went through all of those in the pituitary section. In the milder forms, this would basically have a less mild presentation than the primary adrenal cortical insufficiency. So there'd be no skin or mucosal hyperpigmentation because in this case ACTH and MSH will be low, no hyperkalemia, and usually aldosterone synthesis, because that's regulated through the renin-angiotensin system, is still functional. And the gland is still functional, it's just not being properly stimulated by ACTH. So usually the blood pressure dangers of severe hypotension don't occur with secondary adrenal cortical insufficiency. Tertiary would be from suppression of CRH from the periventricular nucleus in the hypothalamus, and this is going to be most commonly seen in patients who are on steroids, exogenous steroids, who then abruptly stop without tapering. So that can initiate a tertiary adrenal insufficiency. The symptoms and presentation are very similar to secondary, so they're milder symptoms than the primary adrenal cortical insufficiency. Aldosterone synthesis usually here is unaffected. And then peripheral, this I put a question mark here because it's very rare. There's some controversy about this, and this would be due to genetic mutations or lack of glucocorticoid receptor activity. And then I put another category here, functional, which we'll talk about in more depth because I think clinically we see this a lot more. And this is not Addison's. The gland is still functioning, still secreting, but what we have a dysregulation of is the HPA axis. So instead of getting, for example, a nice cortisol awakening response in the morning, we're maybe having a flat cortisol and then it surges again in the afternoon or early evening, or we could have a very, very dramatic cortisol awakening response with a lot of anxiety in the morning, and then that drops precipitously and then again spikes up again. So we can have various dysregulations of that. This is not really recognized biomedically, but it certainly is discussed in the research literature around cortisol. So we might see the decreased cortisol awakening response, also decreased DHEA, and then aldosterone synthesis again would be preserved here, so again, we're not going to see the more life-threatening situations. So when we talk about adrenal cortical insufficiency with the primary, this is our most serious one. This one is going to need actual replacement with cortisol, hydrocortisone, again, is another name for cortisol, and fluorocortisone, which is the mineralocorticoid replacement, versus secondary and tertiary and functional are going to need less of the actual replacement therapy. Especially with functional, we almost never are going to use cortisol or hydrocortisone replacement for that. We want to use more level 1 therapies, diet, exercise, lifestyle, stress reduction, as well as level 2 therapies with herbal therapy, acumoxa, micronutrients, and so forth. All right, so that's the overview of adrenal cortical insufficiency. The other would be excess, and the classic name for this, for any cause causing adrenal cortical excess with high cortisol, is Cushing syndrome. Now we can have high aldosterone as well, and that's known as Con syndrome. I'll talk about that here in a minute. But basically, high cortisol due to any cause causes Cushing syndrome. And this presentation is more weight gain, truncal obesity, hypertension, hyperglycemia with insulin resistance, very much like metabolic syndrome, moon faces, buffalo hump, skin changes with thinning, purple striae, especially around the abdomen and the thighs, osteoporosis, and then potentially amenorrhea and immunosuppression as well. So those would be all classic manifestations of Cushing syndrome. Now here again, it can be primary, or we call it generally ACTH independent, and this is going to result in a decreased ACTH because the adrenal gland or an exogenous source is putting too much cortisol into the blood, and that suppresses the pituitary ACTH. So exogenous steroids are going to be the most common cause of this, but less commonly you can have an adrenal adenoma or hyperplasia of the adrenals, or a carcinoma, very, very rare, but possible in the adrenals. And these could all hypersecrete cortisol. Now, again, if it hypersecretes aldosterone, that would be an aldosterone-secreting tumor, and that would be Con syndrome. So that's going to be different than Cushing's. But Cushing can have hypertension because of the fact that cortisol, again, can act as a weak mineralocorticoid. Secondary Cushing's would be essentially ACTH dependent. This would be from primarily a pituitary adenoma that is hypersecreting ACTH. So we call that Cushing disease. So there's a difference between Cushing disease and Cushing syndrome. This is the most common endogenous cause of elevated cortisol, much more common than adrenal adenoma, for example. So that'd be a pituitary adenoma hypersecreting. You can also have ectopic ACTH production, and this is usually from a paraneoplastic syndrome, especially small cell lung cancer, bronchial carcinoid cancer, and so forth. And this would result over time in adrenal hyperplasia as the adrenals are constantly stimulated by ACTH. So those are the two causes of the ACTH dependent or secondary Cushing's. Now the question is, is there a functional Cushing's? And that's where we call this physiologic Cushing's, and that is a biomedical term. So unlike the deficiency, the HPA axis dysregulation, we call this physiologic Cushing's. What I typically think of clinically is that we can have both of these involve HPA axis dysregulation. One, though, is more on the low side, one is more on the high side. So we can think of physiologic Cushing's as more of an excess dysregulation, and that results in some excess cortisol. The important thing is, if we do a 24-hour investigation of cortisol, we find in Cushing's that there's no circadian rhythm of the cortisol. So if this is a graph, this is the amount through time, and this is the amount of cortisol. We find cortisol usually in Cushing's just as flat like this. In physiologic Cushing's, you still might see a circadian rhythm, but again, it's going to be dysregulated, high at times where it should not be. Same with Addison's. We're going to see loss. In true Addison's, you're going to see a loss of the 24-hour rhythm, so it's going to be flatlined. But in the functional, we might see a rhythm still, but again, it's going to be, the timing's going to be wrong. Physiologic Cushing's, we also call it pseudo-Cushing. This is going to be associated with any condition that alters the cortisol production. and it's going to have some of the clinical features of Cushing's and hypercortisolism. And I'll go over those causes like pregnancy or severe stress, things like that. Again, this would all cause HPA axis dysregulation. Okay, so that's a quick overview of the cortisol disorders. Again, aldosterone is going to have its own tumor, and that's from an adrenal adenoma causing Conn syndrome. So here I just put this together, another little table to make it a little bit more clear, hopefully, looking at the true adrenal cortical deficiency and the true excess, and then the more functional disorders in the middle here. So we have adrenal insufficiency with low cortisol, DHEA, possibly low aldosterone in primary Addison. That can also be related to an adrenal crisis. In here, we're going to see very low blood pressure, low sodium, high potassium, low glucose, and metabolic acidosis. No or little circadian rhythm of the cortisol. Autoimmune is most common, but also infection. Metastases of tumors from other cancers that metastasize to the adrenals can cause adrenal destruction. There can be infiltrative disease like sarcoidosis and hemochromatosis. And then various medications can impair the adrenal function as well. I'll go over those later. Secondary would be, again, a pituitary problem of low ACTH, and so that's going to cause low cortisol DHEA but normal aldosterone. Less severe, less of a chance of an adrenal crisis. And the most common reasons for that would be steroid withdrawal or pituitary disorders. Jumping to the other end, again, Cushing's syndrome is anything that elevates cortisol, and usually DHEA is going to be elevated with that as well. No circadian rhythm of the cortisol. Here, increased BP, increased sodium, and decreased potassium, increased glucose, and central obesity. Primary would be from exogenous steroids, again, providing the excess cortisol, or an adrenal cortical tumor, like adrenal cortical adenoma. Secondary would be ACTH dependent, and that would be either Cushing disease from pituitary adenoma or ectopic tumors, which are releasing ACTH. And then I put on here hyperaldosteronism, and that's going to be the Conn syndrome. High blood pressure, high sodium, low potassium again, metabolic alkalosis in this case. And then Conn syndrome, again, we have high aldosterone, low renin, because your sodium levels are going up, the kidneys are realizing we don't need as much, so that's going to decrease the renin secretion. And the most common reason for this is an adrenal tumor, adrenal adenoma in the zona glomerulosa, which is hypersecreting. And then secondary hyperaldosteronism could occur as well. That's going to have high aldosterone with high renin. And the most common cause for this would be either renal artery stenosis, so you're getting less blood flow into the kidney, so they're sensing that and they start churning out more renin, and that in turn raises aldosterone, or congestive heart failure, liver cirrhosis, or kidney disease, nephrotic syndrome. All those could be causes of secondary hyperaldosteronism. All right, so that's the two extremes there. And then we have our functional disorder, pseudo-Cushing, would be increased HPA axis dysregulation. We have increased cortisol 3 times over the upper limit, and often an increased cortisol awakening response. There's a circadian rhythm that's present, but it's disturbed. And the symptoms are similar to Cushing's syndrome, but it's more mild. We think it's due to potentially increased CRH or dysregulated hypothalamic signaling there. And there's various causes, some with Cushing-like features, so that's pregnancy, severe obesity, PCOS, very severe psychological stress, major depressive disorder, severe diabetes mellitus, type 2 in particular, chronic alcoholism, chronic illness, chronic pain, being hospitalized, and then obstructive sleep apnea. And then others have fewer of the Cushingoid features, so malnutrition, anorexia, intense chronic exercise, hypothalamic amenorrhea, which results from overexercise with low caloric intake. We get less hypothalamic hormones. Increase corticosteroid binding globulin, which would increase the total amount of serum cortisol, and then glucocorticoid resistance. So we basically will check for Cushing syndrome in those patients, but if we find some more mild form, we're generally going to go lower in the therapeutic order. Versus in true Cushing syndrome, I'll talk about the different therapies for that. Many of them are very suppressive to try to suppress the amount of cortisol in the system. Finally, with functional adrenal cortical deficiency, we can call that pseudo-Addison. Again, this is what a lot of people in the naturopathic circle might call adrenal fatigue, but it's kind of going to be the HPA axis dysregulation with a decrease cortisol awakening response with circadian rhythm, but we're going to have it disturbed. And symptoms are going to be more mild, but similar to true adrenal cortical insufficiency. Again, maybe have a suppressed CRH. So this is not currently a biomedically recognized condition, but again, we're seeing evidence for it in the literature, research literature, when people study cortisol rhythms, especially salivary cortisol, with things like chronic fatigue and so forth. So those are all of your adrenal cortex disorders. In the following videos, we're going to go into each of these in a lot more depth.